So the standard therapy for patients with stage 2 and 3 HER2-positive breast cancer is neoadjuvant therapy with multi-agent chemotherapy plus 2 anti-HER2 antibodies, trastuzumab and pertuzumab. And that results in pCR rates of about 60% and 3-year disease-free survival of about 92%. So the purpose of ECOG-ACRIN or EA1181 is to use a less intensive therapy, neoadjuvant, single agent taxane, plus trastuzumab and pertuzumab for 12 weeks or 4 cycles, and then to complete a year of HP, use radiation and endocrine therapy if indicated, and to see if for the patients who get a pCR with that less intensive regimen, if the outcomes are equivalent to those who get a pCR with the standard more intensive regimen. So that primary aim of the trial needs longer follow-up. We have completed enrollment and patients are being followed, but we do need longer follow-up for that primary aim. What we're reporting on at this meeting is the pathologic complete response rates, the pCR rates, for the entire group as well as for the ER-negative and the ER-positive disease cohorts, but also importantly, the clinical and the molecular predictors of who got a pCR. So as we start to use these less intensive, de-escalated approaches, it will be really important to know how to optimally select the patients who are the best candidates for this kind of less intensive therapy. And that's what we were reporting on at this meeting. So the study enrolled over 2,000 patients and 2,141 patients who had, again, stage 2 or 3 HER2-positive breast cancer. 2,141 received at least 1 dose of the taxane plus the trastuzumab and pertuzumab, and that's our population that's evaluable for response. And we separated the 2 cohorts, the ER-negative disease and the ER-positive disease. About a third of the patients had ER-negative disease and about 2/3 had ER-positive disease. And so 95% of those patients completed their 4 cycles of neoadjuvant therapy and went to surgery per protocol, and we are reporting on them. And what we found was that overall, the pathologic complete response rate was 44%. It was about 64% for ER-negative disease and about 34% for the ER-positive disease. But importantly, what we did was looked at clinical and molecular predictors of pCR. So for the clinical pathologic factors, we found that estrogen receptor negative disease, as many have known, has a higher pCR rate. But among the ER-positive disease, about a third of the patients had a lower estrogen receptor expression level, 70% or lower. And those patients had a higher pCR rate. So if the ER level was 1 to 10%, the pCR rate was 63%, similar to ER-negative disease. And if the ER was 11 to 70%, pCR rate was 52%, so very good. Second, we found that if the tumor had IHC of 3+, then that was a significant independent predictor of pCR. And finally, surprisingly, we found that the choice of taxane made a difference. So about 2/3 of the patients had received weekly paclitaxel as their taxane, and about a third had received once every 3-week docetaxel. And we found a higher pCR rate with the use of the paclitaxel, and that wasn't due to amount of expected drug received. So that was a bit of an unexpected finding, but we found those 3 clinical pathologic factors were helpful in predicting who would have pCR, the ER level, the IHC 3+, and the use of the weekly paclitaxel. We then used a molecular tool called HER2-DX pCR score. And this is a genomic tool that combines gene expression of the tumor for various things like immune activation, luminal differentiation, HER2 expression, proliferation, and it combines it with some clinical parameters, the tumor size and whether the nodes were involved. And we used that HER2-DX score, the pCR likelihood score, and found that for the patients who had a high HER2-DX score versus a low HER2-DX score, there was about a 40% difference in the pCR rate, and that was true whether the tumor was ER negative or ER positive. So then we actually did a multivariable analysis. We took the HER2-DX score and we took our 3 clinical pathologic factors that we had found, and we analyzed them all together and found that the clinical pathologic factors remained significant. The HER2-DX score was significant. And so these molecular and clinical factors, each independently, were helping to predict who would get a pCR with this less intensive regimen, the THP. I would caution that we need longer follow-up to ensure the primary aim of EA 1181, namely that a pathologic complete response rate obtained with less intensive therapy is equivalent to one achieved with standard therapy. And I think that until we have that primary aim, standard neoadjuvant therapy should be used. But I think that in the meantime, we should be analyzing, as we've been doing, which are the predictors so that if that is a successful approach and we adopt that, how can we optimally select patients who are going to do best with this less intensive therapy? We are also going to be looking at radiology, so radiomics, MRIs. There are some other molecular tools such as circulating tumor DNA that we'll be looking at. So we're sort of using this time to try to really get ready that if that approach is green-lighted, we really can help select the patients who are going to be best for this approach. I think it was just a wonderful effort. Although it was led by ECOG Akron, the Alliance, and SWOG, and NRG, and many of the collaborative groups in the United States participated. So in order to do this kind of prospective trial with over 2,000 patients, it took a lot of cooperation and collaboration between all of the cooperative groups in the United States.